albeit virtual, grand rounds that we hold annually in honor of Dr. Diller Groff, and Dr. Downard has a few words to talk about his legacy and contributions to our pediatric and pediatric surgical program. And my job is to introduce properly Dr. Downard. Cynthia Downard, she attended Vanderbilt University, where she got her degree in and graduated with honors in French before attending Vanderbilt University School of Medicine. She then went on to do her residency in general surgery at Oregon Health and Science University. And during residency, and the usually long and hard road to become a pediatric surgeon, she spent 3 years in Boston at Boston Children's as a fellow in surgical critical care and also as a clinical research fellow, during which time she also scored a Harvard master's degree. And after residency, she performed her fellowship in pediatric surgery at Emory University. And we were fortunate to recruit her to the University of Louisville when she completed her training, where she has risen rapidly through the academic ranks and is now the Nagaraj Endowed Chair and Professor in the Department of Surgery, as well as Surgeon-in-Chief at Children's Hospital and Chief of the Division of Pediatric Surgery. Dr. Downard has had very innovative laboratory translational research. She's going to tell us some of that today, I'm sure. She's had some successful grant funding and has published widely and has made innumerable contributions to our educational program as well as our research program, and of course clinically as a busy pediatric surgeon. Dr. Downard does it all, and one of the people I'm most proud of and thankful that we recruited here. And so Dr. Downard, thank you for all that you do, and especially for giving this grand rounds and in honor of Dr. Groff, who for many years, along with Dr. Nagaraj, performed incredible service to the most difficult pediatric surgical patients in this region. So in his honor, we have this event every year, and it's worthy of remembrance. Thank you.
Thank you for the kind introduction, Dr. McMasters. I'll just share a little bit about Dr. Groff. So he's a native of Washington, D.C., and practiced pediatric surgery in Louisville for 23 years before his retirement in 2004. He is a Haverford College graduate and Duke Medical School graduate as well, and then went on to do his general and thoracic surgery training at George Washington Hospital in D.C. He then spent some time with Dr. C. Everett Koop, the former Surgeon General who was a pediatric surgeon, and Dr. Stan Dudrick, who really is credited with founding or with creating parenteral nutrition. And Dr. Groff was intimately involved in the puppy experiments where they kept puppies alive just on parenteral nutrition. Dr. Groff, as you'll see on the next, Dr. Dudrick, as you'll see on the next slide, was one of our Groff lecturers. Dr. Groff then came to Louisville and was the chief of pediatric surgery and established the ECMO program at Norton Children's Hospital in 1985 alongside Dr. Larry Cook in the neonatal intensive care unit. Dr. Groff currently lives in North Carolina to be near his children. And the next slide here shows the Groff lecturers over the last it's now 17 years. We've had Dr. Foley and I pinch hitting the last 2 years, but you can see that this is a veritable who's who of pediatric surgery, including, as I mentioned, in 2010, Dr. Dudrick, at Dr. Groff's request, came to speak. So So with all that said, thank you to the Children's Hospital Foundation and to Dick and Kay Groff for endowing this lectureship. Thank you to the Division of Pediatric Surgery and the Department of Surgery and the Department of Pediatrics for hosting this lectureship every year. And hopefully next year we can get back on track with the usual joyous celebration that accompanies this lectureship. So to move into the topic at hand, today I plan to review the epidemiology and pathophysiology of necrotizing enterocolitis, discuss a few experimental observations, and then talk about new advances in the diagnosis and treatment of necrotizing enterocolitis, and think about some next steps for intervention. And before you log out and say, oh, this is a boring basic science lecture, I really want to make it a story of basic science research and how, as clinicians, we can be very involved in improving the care of our patients. So necrotizing enterocolitis is, of course, a devastating disease. It is a common gastrointestinal emergency in newborns. And as newborns survive more and more of their pulmonary morbidity, especially premature newborns, necrotizing enterocolitis is poised to become one of the leading causes of death in premature infants. Here you can see on the x-axis birth weight groups in grams, and then the incidence of necrotizing enterocolitis on the y-axis. And you see in the very low birth weight babies, the 500 to 1,000 gram babies, the incidence of necrotizing enterocolitis is highest. And then as babies progress in weight, which is a surrogate for progressing in development, they have a decreased incidence of necrotizing enterocolitis over time. This is a little bit different look at the gestational age rather than the weight, and on the x-axis, and then on the y-axis is not only necrotizing enterocolitis, which is in the white and black bars, but also in the gray bars you have an entity of spontaneous intestinal perforation. That's a little bit different etiology that I don't know we understand completely. However, it is associated with treatment of patent ductus arteriosus, with whether it's indomethacin, ibuprofen, Tylenol more recently. So it is an entity, but unless the baby has an exploratory laparotomy, a lot of times you don't know whether it was truly necrotizing enterocolitis or a spontaneous intestinal perforation. But a lot of studies mix the two entities. So necrotizing enterocolitis, as I said, the gestational age at birth matters. However, the presentation is different based on the gestational age. So if babies are born less than 30 weeks, they usually have a couple of weeks until they develop necrotizing enterocolitis. If they're at 31 to 33 weeks gestation, it's usually a little bit shorter duration until they develop NEC. And term or near-term babies have a very short course before they develop NEC, and it seems to be almost a different disease process. So necrotizing enterocolitis may be related to intestinal recorded so-called outbreaks in neonatal intensive care units. It doesn't seem to begin until after babies are fed usually, but can happen in babies who haven't been consistently fed. It does not seem to be easily replicated in the sterile GI tract, and the types of organisms that are implicated are varied and common. So there's no definite infectious etiology. It's important, though, with any sort of disease process that you have a clinical staging system so that you can discuss patients consistently across different medical entities. So necrotizing enterocolitis forever, we've used the Bell staging system, although there's a little bit of discussion later in the talk about changing this. And basically, Bell's system has 3 stages. Stage 1 is nonspecific systemic signs of illness, the typical apnea, bradycardia, temperature instability that we see in premature babies when they're ill. You can have increased gastric residuals as a result of the intestinal tract not working, a little bit of abdominal distension, and you may have bloody stools, but that's more with a late stage 1 presentation. Stage 2 can have some of the same nonspecific systemic signs with a little bit increased distension, some absent bowel sounds, some increased abdominal tenderness. But then late in stage 2, the babies are increasingly ill, may have a metabolic acidosis, some thrombocytopenia, increased tenderness, and maybe some erythema or other discoloration of the abdominal wall. Stage 3, which is the end stage necrotizing enterocolitis, is really the diagnosis is not in question. This is, you see babies with hypotension, respiratory failure, usually intubated, severe acidosis, marked abdominal distension, signs of generalized peritonitis, and then late stage 3 is when you see intestinal perforation. So laboratory diagnoses, people try to look and see are there any early signs of necrotizing enterocolitis. General signs such as hyponatremia, acidosis, as I mentioned, anemia, thrombocytopenia is a pretty classic hallmark of NEC, and you can have positive blood cultures. Radiographs really are the hallmark though. So this is a baby with necrotizing enterocolitis, and you can see that this is pneumatosis intestinalis in the walls of the intestine. And then this is a baby with severe necrotizing enterocolitis. You can see the ground glass appearance through all of the intestine here. Very distended stomach. This nasogastric tube is not doing a very good job of decompressing that stomach. It may not be hooked up to suction. But then the hallmark sign that is present in this radiograph is portal venous gas. And that's when you see these little air lines in the liver itself. And that is a ominous sign, presumably from pneumatosis intestinalis, the air in the wall of the intestine that has tracked up through the mesenteric vasculature and is actually in the portal venous system of the liver. So the problem with necrotizing enterocolitis is that the treatment remains largely supportive. Generally, you stop feeding the baby, nasogastric decompression, replace their fluids, start parenteral nutrition, hold feeds, and then wait on an undefined amount of time based on football scores, I think, until they have no radiographic evidence of disease. In general, broad spectrum antibiotics are implemented, and those vary based on the hospital, the microbiome that's seen at that hospital. You can obtain fluid samples, paracentesis. I really think that this is useful if you have a baby who you really, really want to operate on, but they don't have any hard signs that they need an operation. And if you do a paracentesis and obtain either enteric contents straight up or have a positive gram stain, that can imply gangrene of the intestines and maybe a perforation of the bowel that you're just not seeing on plain radiographs. So pneumoperitoneum is really the only absolute indication for operative intervention. However, there are several relative indications. Having a fixed dilated loop of bowel on serial radiographs, portal venous gas, as I mentioned, abdominal wall erythema, the peritoneal fluid cultures, and then really progression despite medical management. And that's where a multidisciplinary conversation is very important. So this is the baby's when they have necrotizing enterocolitis, and you can see the discoloration around the umbilicus. You can see discoloration along the side of the abdominal wall. This baby is very, very distended, and I can bet if you pressed on their abdomen, it would hurt. So about a quarter of babies who develop necrotizing enterocolitis require surgical treatment. The survival is between 70 and 80% overall. The survival for surgically treated patients who presumably have more severe disease is worse than babies who are medically treated. I don't think it's a function of the surgery. I think it's a function of the underlying disease process. And babies with necrotizing enterocolitis can have long-term sequelae such as short gut, but they can undergo intestinal adaptation. So a question that you may see on the pediatrics boards, or I think this is on surgical questions as well, is if you have babies who have short gut from various intestinal causes such as gastroschisis, necrotizing enterocolitis, those with necrotizing enterocolitis are the most likely to get off of parenteral nutrition long term. You can also have bowel strictures with medically necrotizing enterocolitis, and you can have adhesive obstructions that you can have with any sort of operative intervention. So this is a baby who underwent an exploratory laparotomy, and you can see, oh sorry, it didn't advance. You can see that the intestine is questionably viable. And so this is similar to a temporary closure in adults. In babies, we have silo bags that we use frequently for gastroschisis treatment, and this can be used as a temporary closure in babies so that we can keep almost a continuous eye on the intestine. So as I said before, the problem with treatment for necrotizing enterocolitis is that it's frustrating. If you operate too early, it may be unnecessary. If you operate too late, there may be nothing to do other than have a direction of care conference with the family. And so, I was very frustrated with this and thought we should look for alternate treatment strategies. So important in any research effort is if you want to make quick advances, you need a good animal model. And so what I was looking for is an animal model with similar histologic changes of necrotizing enterocolitis with similar causative factors that could be reproduced over a short time range but be very reliable, easy to work with, and relatively inexpensive, because research funding is not unlimited, certainly. So what I landed on is this article from 1975 from the journal Surgery by doctors Barbara Barlow and Thomas Santulli, who are big names in pediatric surgery, the importance of multiple episodes of hypoxia or cold stress on the development of enterocolitis in an animal model. And this, although it was developed in 1975, is still the gold standard model that is used today. So in this model, hypoxia and hypothermia were determined to be critical events in the development of necrotizing enterocolitis. And they formula-fed rats 300 kilocalories per kilogram per day, and then subjected them to a hypoxic stress where they put them for 3 to 5 minutes in a baggie. And the story goes that Dr. Barlow, when she was a research resident, would put the animals in a baggie and put them in her pocket in her white lab coat. And then when they stopped moving around, she knew that they were subjected to enough hypoxic stress. The hypothermic stress was then 5 minutes in a 7°C refrigerator. And with this animal model, 100% of their animals developed necrotizing enterocolitis after 2 hypothermic and 4 hypoxic stresses. So I had the good fortune of, pediatric surgery is a small group. And so I read about this model and then read more recent papers and found that it was still being used. And so I contacted Dr. Gail Bessner, who's at Nationwide Children's Hospital, who is a leading researcher in necrotizing enterocolitis, and went to her lab. She was gracious enough to say, sure, come on up and I'll show you how we do it. And so we replicated the animal model as it's performed in her lab. And these are the rat babies that are born 1 day prematurely, which is the equivalent to about 33 to 34 weeks gestation. They are then stimulated. So they're born by C-section. They are then stimulated and placed into an incubator, which the Children's Hospital graciously donated to our laboratory, kept warm, and then formula fed using a 1.9 French PIC catheter, formula fed for 4 continuous days with ever increasing amounts of basically puppy formula that is fortified, and subjects them to significant hypothermic and hypoxic stresses. And with those changes, and if you're offended by animal research, you probably want to close your eyes for the next slide. But this is a baby rat at necropsy, and this is the head over on this side, and these are the legs on this side. This is their intestine with severe pneumatosis intestinale. This is a very distended stomach. And with those changes, okay, you can open your eyes back up now because we're on histology. This is normal neonatal rat ileum, and then this is neonatal rat ileum. Thank you to Dr. Debsky for helping to process these specimens. Normal neonatal rat ileum, and then rat ileum that has completely separated from the basement membrane. So this is grade 4 necrotizing enterocolitis, and the grading system pathologically goes from grade 1 to grade 4. So this is the most severe type of necrotizing enterocolitis. So we have the animal model. There have been little significant progress in the last 60 years in necrotizing enterocolitis treatment, and so I wanted to look at alternate strategies for therapy. And so, having done an adult surgical residency, I knew that there were adult surgery problems with poor intestinal perfusion, shock, and multi-system organ dysfunction syndrome, which we just discussed in the last hour in surgical morbidity and mortality conference. So if you have, and we discussed this exact thing, the shock perfusion triangle, the lethal triad, really, of decreased heart function, decreased intravascular volume, which results in tissue microvascular dysfunction, then this is what kills you, whether it's from an initial insult or from a ruptured spleen. This is what will kill you. So there was a recognition, and this is with Dr. Neil Garrison in the Department of Surgery and Dr. Jason Smith, but this was a little before mine and Dr. Smith's time in the lab. Dr. Zakaria, who is a an adult nephrologist recognized that conventional resuscitation did not restore intestinal blood flow. So just giving back blood products and crystalloid did not adequately restore intestinal blood flow. And the thought was that the intestine not being perfused could be the motor that drives the multi-system inflammatory response. So in Dr. Garrison's lab, there was a consistent model of hemorrhagic shock in adult rats, where the rats were bled down to a low blood pressure and then resuscitated using crystalloid and colloid and blood products. This resulted in a restoration of blood pressure and heart rate, but showed continued intestinal vasoconstriction with this conventional resuscitation. And so Dr. Zakaria, being a nephrologist, said, well, what if we put a little bit of peritoneal dialysis fluid solution in the abdomen? What happens to the intestine at that point? And what they saw was an immediate and sustained vasodilation of the intestinal microvasculature, and termed this peritoneal resuscitation. And this is still occasionally used at University Hospital and other hospitals, other trauma hospitals in the United States. So the way that this was measured is using intestinal video microscopy. And what we're looking at in the next couple of slides here, if this is the intestinal mesentery, it goes out, and this is the intestine itself here. And so this is a blown up picture down in the left side. The A1 arterioles are the primary arterioles that come out of the mesenteric vessels. They then the A2 vessels, and then the A3 vessels are the ones that actually go out into the intestinal villus. And so you can imagine you need a very powerful microscope in order to see these. And special thanks to Paul Matheson, who's a PhD researcher primarily located at the VA, who was instrumental in all of these experiments and created these slides too. So intravital video microscopy, which was used on the adult rats in the hemorrhagic shock model, involves placing a rat on a microscope stage and exteriorizing their intestine. So the rat is laying on their side, and the intestine is exteriorized and then splayed open, and the light shines through the intestine. And what you can see is the intestinal microvasculature on the video microscope, and you can see the actual blood cells flowing through the intestinal microvasculature. This involved a tracheostomy. This involved a central line in the rat to measure their cardiac output. And so I thought, well, so we did this in the adult rats, so we can try and do this in the baby rats and see if we can measure these same reproducible outcomes in the intestine. So pretty quickly we figured out that the thermodilution cardiac output and putting central lines in these you saw how little the teeny tiny little babies are, was not going to be a doable prospect. Plus they're much, much smaller. Now, just by way of background, the solution that we're using is Delflex, which is a 2.5% dextrose solution, and you can see the other components here. And mechanism of action is not exactly clear on how it dilates the intestinal microvasculature. It may be the hyperosmolarity, the glucose degradation products, increased endothelial cell dilator capacity via nitric oxide, adenosine and nitric oxide receptor inhibition can prevent this vasodilation. So not exactly clear how it works, but it is reproducible and sustainable. So my thought was, if this works in the adult rats, and if microvascular circulation is the primary physiologic event in necrotizing enterocolitis, could peritoneal dialysis solution cause significant intestinal vasodilation in the neonatal intestine? So all this said, I tried and tried, and Dr. Matheson tried and tried and tried to recreate the same animal model in the teeny tiny little baby rats. So this is 2 years worth of work, finally. We connected enough data, and I would draw your attention to the numbers of animals, 4 animals and 1 animal, and I can't even tell you the number of animals that we used to try to get these minimal results, but basically showed that the intestinal, arterial, and venule diameters measured over time in dam-fed neonatal rats were able to be measured, but they were very, very small. And this is measured again in microns. This is without the necrotizing enterocolitis part of the animal model. Now next we'll look at the necrotizing enterocolitis part of the animal model. And so we showed that in the control animals in black, the A1, and again, these are the blood vessels that are coming straight off the mesentery. A1 arterioles were significantly smaller in animals with necrotizing enterocolitis, and the A3 arterioles were definitely smaller in animals with necrotizing enterocolitis as compared to controls. However, the veins were not significantly different. And this is just a baseline. So we had a reality check. Again, going back to our animal model, we wanted to have similar causative issues, histologic changes, et cetera, but when you get down to the reliable and reproducible, easy to work with, and relatively inexpensive, we were not at all in that realm. And so thought it was time to look for a different solution. So rather than changing our animal model, which was widely used, we looked for different outcome measures. And what we settled on was laser Doppler flow studies. And basically, rather than having the animal up on the microscope stage, we took a laser Doppler flow probe and placed it directly on the intestine. And the flow, this is similar to just plain Doppler studies. You can measure the flow in these intestinal microvessels and the microvasculature. So this is what it looks like. We had rat babies anesthetized. This is a surgical glove with the end cut off, hooked up to an isoflurane machine. And then this is the laser Doppler flow probe. And we actually, some of the experiments, and I apologize, I don't have a picture of this, we used a paper clip to create a little tissue bath, if you will, on their skin so that we could put the additives in and keep the concentration consistent. So with that, and again, this is a couple years of work, we were able to consistently over time with our animal model, again, goes 4 days, so 96 hours, we could measure the changes in intestinal blood flow over time with experimental necrotizing enterocolitis. And what we found in the red triangles here are the necrotizing enterocolitis. The green dots, oops, excuse me, go back. Green dots are control animals, and you can see that at baseline 12 hours, 24 hours, at 48 hours, the time when we really saw a big split in the intestinal blood flow of these animals. So this was like a major aha moment. So then we went back to the original idea of what happens when we add the peritoneal dialysis solution to the intestinal blood flow. So this, having on the previous slide shown that at 48 hours, we saw the greatest difference in intestinal blood flow. We chose 48 hours as our time point at which we were going to do these experiments. And so you see at baseline here, there is a difference between the control animals' intestinal blood flow and the necrotizing enterocolitis animals' blood flow. However, when you add direct peritoneal resuscitation or peritoneal dialysis fluid, you see that the blood flow increases in both the control animals and in the necrotizing enterocolitis animals. However, in the necrotizing enterocolitis animals, they seem to at least get up to what the baseline was in the control animals, which presumably would be enough to save intestine. This was a major deal. If you look at 24 hours, and again, this is why we stuck with 48 hours. If you look at 24 hours, the brighter green and red dots and triangles, the numbers are basically superimposable. And so we thought that that was not a great study. It did increase the intestinal blood flow in both groups, but thought that that would not be super beneficial as far as what we were looking at. So presumably, if you have a teeny tiny baby and you're putting 2.5% dextrose into their system, they're going to have some sort of response to that, including hyperglycemia. And so we wanted to look at different concentrations of dextrose to see if we could get the same beneficial effect while minimizing the toxicity of treatment. And so I would use this as an example of the Summer Research Scholars Program through the medical school. Matt Schreiner was a medical student who worked with me through that program and did this experiment. And Sarah Walker was a research resident, surgery resident in the Department of Surgery, who is now a practicing pediatric surgeon. And again, thanks to Dr. Matheson, Dr. Smith, and Dr. Garrison, who were instrumental in these experiments as well. So in this set of experiments, again, we showed that the direct peritoneal resuscitation did augment conventional resuscitation, but we wanted to decrease the hyperglycemia and the hypovolemia that you would presumably see with the hyperosmolar situation. So we wanted to look and see if this necrotizing enterocolitis therapy increased intestinal perfusion while minimizing the risk of hyperglycemia. This is the difference in the concentration of the various components of the two solutions. I would draw your attention most importantly here to the dextrose. And what we saw is that over time, and again, this is hours post-delivery, so 48 hours is when we saw our biggest change, and these are several animals that are averaged. The necrotizing enterocolitis animals had baseline lower blood flow. However, with the addition of both 2.5% and 1.5% direct peritoneal resuscitation fluid, they had an increase in their intestinal blood flow. The blood glucose levels of the control animals you see here at about 125. However, the necrotizing enterocolitis animals with the 1.5% went up to about 175, and the blood glucose levels with the 2.5% dextrose went up over 200. So presumably we got a similar effect with the intestinal blood flow, but less hyperglycemia. So that was our goal. So we determined that the 1.5% was just as effective as the 2.5% increasing intestinal blood flow, but less hyperglycemia. So mission accomplished. Next, we looked at the role of prostaglandins in necrotizing enterocolitis. And so prostaglandin E2 is the primarily intestinally active prostaglandin. It's responsible for mucosal integrity. And I mentioned before that there are babies who develop spontaneous intestinal perfusion after treatment with indomethacin for a patent ductus arteriosus. This is a non-selective prostaglandin blocker, and so we thought that if we saw an increase in intestinal blood flow after topical application of a non-selective prostaglandin inhibitor, that this could be somehow related to that treatment with indomethacin, excuse me. And so the primary receptor of prostaglandin E2 is EP4. And what we thought was that if prostaglandin E2 played a critical role in the intestinal microvasculature in necrotizing enterocolitis, we should be able to reproduce this in our animal model. And again, we use the laser Doppler blood flow measurements to look at the blood flow at 48 hours of life. This is a little bit of a busy slide, but again, it shows the intestinal blood flow in necrotizing enterocolitis and control animals at 48 hours of life. And then we applied prostaglandin E2 and saw an increase in the intestinal blood flow in our NEC animals up to the level of the control animals. So we saw that we did have increased intestinal blood flow in the NEC animals up to the level of control animals, and we thought maybe there would be a potential for therapeutic intervention while babies are being treated with patent ductus arteriosus. And this is where Dr. Hannah Fisher, one of our neonatologists, was a neonatology fellow, and so I drug her into this research arena. So we wanted to look and see if human levels varied over time with treatment of indomethacin. And so what Dr. Fisher did as her research project was a pilot study with 10 human infants. We had to have them weigh greater than 650 grams because of the amount of blood that we needed to draw to get these levels. They had to have an intent to treat with indomethacin and no prior exposure to indomethacin or ibuprofen because we didn't want to alter our results. And so what she looked at is babies who had a blood sample drawn prior to their first indomethacin or ibuprofen dose, and then prior to their second dose. So somewhere in here, we wanted to see if the levels had decreased prior to their second dose of indomethacin. And so we measured both serum prostaglandin E2 and metabolites. And then this last graph here, and the next slide is a little bit clearer, shows an overall decrease in the level of prostaglandin E2 and the metabolites after treatment on the x-axis here, pre-indomethacin and post-indomethacin. And so this is a summary of all of those data points put together. Basically, prostaglandin E2, the prostaglandin E2 metabolites, and then if you add all of those together, decreased significantly before and after administration of indomethacin. So again, this was the pilot study. We only had 10 patients. We didn't have enough data to determine whether the dose mattered as far as the closure of the patent ductus arteriosus, but wanted to be sure that this was a safe study and would be possible to do in a larger patient group if anyone's looking for research projects. So as Dr. McMaster said, I was a French major in college, and so I always liked the French philosophers. Pasteur was more of a French scientist, but Descartes was both a mathematician and a philosopher. So lots happening in French and in France as far as their philosophy and such. But Pasteur once said that chance favors the prepared mind, and so Dr. Matheson, again, who's the PhD researcher who worked with this, was at a microcirculation meeting and heard an obstetrician, catch up on my slides here, speak about relaxin. And so everybody's heard of relaxin. It's a pregnancy-associated hormone produced by the corpus luteum. It's found in breast milk, but not in formula. It was first localized in the pubic ligaments of guinea pigs and is thought to have reproductive, cardiovascular, renal, and GI effects. And so we asked, did it have any role in necrotizing enterocolitis? Dr. Alex Mackey and Dr. Laura Galgansky and Jessica Shepard were responsible for the majority of these experiments. Dr. Mackey is an attending surgeon now at Audubon Hospital. Dr. Galgansky is a pediatric surgeon, and Ms. Shepard is a high school chemistry teacher in Hopkinsville. So basically, we found that relaxin was secreted in maternal milk. Maternal milk, lack thereof, was thought to be a risk factor for necrotizing enterocolitis, and so our hypothesis was that necrotizing enterocolitis animals had decreased levels of relaxin, and that may be responsible for the changes in the intestinal microvasculature. Again, we used our same animal model with the hypothermia, hypoxia, and administration of lipopolysaccharide, which I did not mention before, but is a critical component in the animal model, and collected tissue and serum. And what we found using Western blot is that in the control animals, there was a band at the pro-relaxin level, which was not present in our necrotizing enterocolitis animals, and a strong band at the relaxin 10 kilodalton line, which was not present in our NEC animals. We then looked at the levels again. The control animals are in blue and the necrotizing enterocolitis animals are in yellow, and looked at the level of relaxin post-delivery, and it seemed to go down until at 72 hours. It was undetectable in our NEC animals, but was ever increasing in our control animals. And then using ELISA, again, at every time point up to 96 hours, the NEC animals were lower than the control animals. So with this set of experiments, we showed that relaxin did seem to be decreased in our animals with necrotizing enterocolitis who were being formula fed. And so we hypothesized then that relaxin, which is a potent vasodilator, could be key to associating formula feeds with the development of necrotizing enterocolitis. So then we asked, well, what happens if we add the relaxin back? So in this set of experiments, we again used the same necrotizing enterocolitis model, but we had 4 groups. One were the control groups that were allowed to suckle from the moms, one where we had formula feeds just to have necrotizing enterocolitis, and then we added back relaxin, to the formula fed groups, looking to see if they just had it with one feed, if it could be sort of a rescue therapy if you had a baby who had already developed necrotizing enterocolitis, or we added the relaxin with all feeds, simulating a baby that may be at very high risk for necrotizing enterocolitis, so that you could just give it to them up front and not worry, you would still worry about development of necrotizing enterocolitis, but try to prevent it. We then sacrificed the animals. We did the laser Doppler flow studies, and then sacrificed the animal and collected their tissues and serum. So what we saw was that the laser Doppler flow studies in the babies who received the relaxin either with one feed or with all feeds were significantly increased compared to both control and necrotizing enterocolitis babies. Again, this was done at 24 hours, so these levels were pretty similar. We also saw that the rat babies who received relaxin with who received relaxin with just one feed did not have a hugely significantly increased level of relaxin. They were more similar to the necrotizing enterocolitis groups. However, the babies who received relaxin with all of their feeds were back up and even slightly above the level of control babies who had received mother's milk. So we concluded from these experiments that oral relaxin supplementation increased the ileal blood flow above the baseline in the necrotizing enterocolitis animals, and that supplementation with relaxin did increase the ileal blood flow as measured with laser Doppler, and hopefully showed that relaxin was able to exert its effect being an orally dosed medication, which could make it an attractive potential therapy. The problem is, though, the overall incidence of necrotizing enterocolitis has decreased over the last 15 years. In spite of all of this extensive research, it's not very easily translatable. And so when you're doing research in neonates, there are a whole bunch of regulatory issues that make it very, very hard to take medications that you might be able to push a little bit more on the experimental envelope in adults and push it into to neonates. There are challenges in funding. You know, the NIH has been incredibly limited in funding, and still back to the laboratory determinations, there are frustrations with making a precise diagnosis of necrotizing enterocolitis until it's almost too late. So in order to combat this, two very interested mothers who had children who died from necrotizing enterocolitis founded the NEC Society, and this was founded in 2014. They very appropriately identified a multitude of stakeholders, including neonatologists, surgeons, nurses, dietitians, and parents who wanted to partner to figure out what are the next steps in necrotizing enterocolitis research. They obtained a PCORI Engagement Award in 2017 and started an in-person educational meeting to discuss and study necrotizing enterocolitis and figure out what are the next best steps. So the NEC Society meets every 2 years. A meeting just occurred. It was supposed to happen in Cincinnati, but this was virtual. And so if you're interested in this, I would keep an eye out for this, this group, because this is really where the progress is happening currently. So I mentioned before the Bell's criteria. One of the suggestions was to get rid of the Bell's criteria and use the quote unquote 2 of 3 diagnosis of necrotizing enterocolitis. So they presumed that babies with a diagnosis of necrotizing enterocolitis would have abdominal distension and ileus and or bloody stools, and then at least 2 of the criteria below: pneumatosis or portal venous air by ultrasound or x-ray, persistent platelet consumption, and a postmenstrual age of disease onset more consistent with necrotizing enterocolitis and the spontaneous intestinal perforation, which I discussed. The patients who were excluded from the diagnosis of preterm NEC: infants who had spontaneous intestinal perforation, complex congenital anomalies, because that's a whole different discussion, infants who were being fed a very minimal amount, or if they were near term, because again, that seems to be a different disease process. There has been a recognition of the importance of enteral nutrition in the development of necrotizing enterocolitis and the formula feedings, as I mentioned, and so using aggressively donor human milk for preterm infants has been a major focus over the last 10 years. It is pasteurized, so it decreases the bioactive components. So back to the discussion of relaxin. I have not sampled the relaxin levels in these very precious donor milk specimens. However, that is at least a thought, and one of the components that I personally think is responsible for the decreased incidence of necrotizing enterocolitis that we've seen is the aggressive use of donor human milk. Another major progress in the NEC Society is a registry and biorepository that allows definition of disease states and data points. So there are 6 participating institutions. We unfortunately are not one of them, but it is housed at Washington University in St. Louis, and this facilitates broad screening and larger studies. So in conclusion, I would say necrotizing enterocolitis really is a great example of a complex patient problem that keeps me and many neonatologists and other pediatric surgeons up at night. And these complex problems are an important driver of not just surgical research, but just medical research in general. Collaboration, as is happening through the NEC Society, is key and important to have invested patient parents or patients themselves if we're talking about adult research. All of the various specialists who deal with these problems to get different ideas. However, surgeons have access to tissue and a clinical perspective specifically in the operating room that others do not. And so I think that being a surgeon scientist is a unique position where collaborating with your colleagues is very important, but persistence as far as research is paramount. And that concludes my presentation, and I'm happy to take any questions if I can figure out how to answer the chat. Let me unshare my screen. So if anyone has questions, I have found the chat. I'm just going to look back through and see if there are any specific questions. Thank you, Dr. Moulter, for commenting on translational research. I think it is important just to remain encouraged more than anything, because especially with funding mechanisms, as I've told many people the story of every time you write a grant, specifically an NIH grant is what I think of. Having had 2 children, writing an NIH grant is sort of like giving birth. It's like you send your grant off and here's my wonderful child, and then they send you a letter back that says, your baby's pretty ugly. I don't think that we're gonna support this one. So is our spontaneous intestinal perforation and necrotizing enterocolitis separate clinical entities? I think they are related but separate, and I think that that's where the NEC Society in that alternate diagnosis and classification strategy has suggested that they really are separate. You see spontaneous intestinal perforation, and that's one of the first questions that I ask if I'm asked to see a baby who is premature. First, what gestational age are they corrected, and then have they received Indomethacin recently? And so if they've received Indomethacin recently, I'm going to be thinking, this may be spontaneous intestinal perforation. Now, is it truly spontaneous? No, because they had some sort of flow state that was associated with that. However, the treatment I think can be different, because those babies who are small, less than 1,000 grams, who have a spontaneous intestinal perforation associated with Indomethacin or whatever PDA treatment administration, those babies seem to do very well with drain placement and then the whole seals, and they can get by without an operation. However, babies with necrotizing enterocolitis, if they perforate, that's more of a global intestinal perfusion process where you are very likely to have other parts of the intestine that are going to be affected. So has anyone used insulin to chase the hyperglycemia in the 2.5 dextrose solution? Thank you, Dr. Asamoah, for that question. This has not been used in this application consistently in the neonatal intensive care unit, and so the answer to that is no, but there are certainly babies who have to undergo peritoneal dialysis because renal replacement therapy, as you know, in neonates is a real challenge, and so so that is part of the regimen. Would be using insulin if you had persistent hyperglycemia, but as you know, especially in teeny tiny babies, it is very challenging for to balance their blood glucose levels. So. Great. Dr. Stewart, I did not know that the University of Louisville was the first to report spontaneous intestinal perforation, so thank you for letting us know that. Any other comments or questions? Great. Well, with that, I think we can sign off. And Department of Surgery, I think we may still have resident conference. Dr. McMasters can correct me if I'm wrong, but I appreciate all of you attending today. And hopefully, again, next year, we have a speaker lined up for the Groff Lectureship, and we'll be back on track. I would like to specifically thank Dr. Foley for pinch hitting last year as well in this position, and look forward to continuing. I'm happy offline too. Anyone's welcome to email me with any questions or concerns, or if you want support, I will gladly support you in your research efforts. So thank you.